Hi everybody, welcome to today's Q&A session on the infections topic. Hopefully you've had a chance to watch the recorded video where we went through all the slides. I did that video. My name's Katie. I'm a pharmacist at Sheffield Teaching Hospitals. I work as a respiratory specialist. I did my exam in March 2021, so I was in the cohort where I should have done it in June 2020. But because of COVID, it was delayed and I practiced provisionally for 9 months and then qualified. So it's 2 years ago. Hopefully can give you some top tips for the exam. If you've got any questions as we go along, pop them in the chat. I'll do my best to answer them. If I can't answer them kind of while I'm talking, we'll come back to them at the end, or we'll get an answer to you out via email, something like that if needed. So hopefully you've covered, well, we're nearly at the end of our revision course actually. So obviously your exam's coming up. Hopefully you're feeling okay about it, you're looking after yourselves. So you've covered over-the-counter, genitourinary, immunity, malignancy, GI and respiratory, cardiology, endocrine, blood nutrition, MSK, CNS, skin, eyes, ENT, and infection is the topic that we're going to be discussing and doing a Q&A on today. And next week, the law and ethics session with the exam prep will be available from next weekend for you to watch. Just a little bit about Pharmacy Foundations. So we are helping the development of pharmacists at all stages. So we work with undergraduates doing some work-based learning, clinical simulation, tuition. Obviously what you guys are on in your foundation year as trainee pharmacists. So doing a mock exam, which is available to book on. We have calculation support, personal tuition, this revision course. We have a podcast and we work with lots of different universities and companies to provide training, and we do CPD events, networking and clinical simulation for postgraduates and qualified pharmacists too. And this is what we did last academic year. So there's some VR learning. We've done kind of GP simulation. You'll be able to see that's system 1 on there. That's kind of a mock-up of system 1, as well as doing some clinical examination skills. Now we're back to face-to-face learning. So meet the team. Let me just let this person in. Yeah. So as I said, my name's Katie. I'm one of the hospital pharmacy clinical tutors. Hopefully you've met me before in some of the sessions. If not, nice to meet you. And as I say, I'm a respiratory specialist pharmacist. I did my pre-reg, as it was then, split between GP and hospital in Sheffield. And once I qualified, as a provisionally registered pharmacist, because as I say, my exam was cancelled, I did 2 years as a foundation pharmacist at Sheffield, rotating through lots of different specialisms, obviously coming across lots of infections, which is what we're going to be talking about today. And now I'm a respiratory and cystic fibrosis specialist pharmacist. So again, covering lots of respiratory infections in particular, but we do kind of have general patients as well. So don't forget to follow us on Instagram, Facebook and Twitter. If you follow us on these social media sites, obviously we promote what we're doing at the moment, what's available, but we also do kind of free access learning. So whether it's quizzes on Instagram or Instagram posts with some bite-sized information. I mean, I still do them now. I'm qualified, but I still do them. And can be quite useful for sort of on-the-go learning while you're commuting to work. If you're on the train or the bus, you can sit and have a look at an Instagram post, interact with it, and we're replying things. So quite good for sort of on-the-go learning, just quick fire, keeps your knowledge topped up. And we also have a WhatsApp support group that you can access via that QR code, and I'll show that again at the end if you miss anything. We've still just got a few people joining, so I'm just admitting them as we go. So as I say, that's the QR code. I'll just leave that on the screen for a second in case anyone's not already part of the group and wants to be. Really helpful for kind of discussing any questions that you've got, and can get quick answers as well from your colleagues and people and your peers. So today's session, first things first, if you've got any questions about the infections topic and what we covered during the recording, then I'd say pop those questions in the chat. You can message them straight to me if you don't want everybody to see your question, and we'll do our best to answer them as we go. But through the session today, So put your questions in the chat. I've got some questions that we've had sent before, so we're going to go through one of those. Go through some popular sections revisited, so covering some of the same slides we talked through in the recording, as well as covering some new slides that hopefully you have had chance to work through on your own, but just kind of giving you what we would have talked about in the slides. I've got a bonus multiple choice question coming up to help. It's about counselling points for TB medications. So hopefully that will be quite useful, and you should have hopefully covered some of these in your revision in terms of what side effects patient needs to look for and things like that. But we'll get there when we get there. And then we'll go back to the chat at the end for any questions about that that you guys have come up with. So hopefully you have some questions. If not, don't worry. If you think of anything as we go along, as I said, just put it in the chat. You can send it straight to me, or you can ask everyone. And obviously this is an opportunity for you to ask any questions and share with your colleagues as well if you can help, if you've got any good resources, anything you're using for your revision. And at the end, I'll answer any general questions that you have as well. So before we get started, could somebody just put a few messages in the chat just to let me know that you are here and you're awake on this lovely Sunday afternoon. It's looking beautiful down here in Sheffield. Hope it's nice with all of you. Someone could just say hello in the chat. Hello, hi. Brilliant. And I want you to get a lot out of this session. It's for you. So if you've got any questions, as I say, put them in the chat. So we had a question over email about malaria prophylaxis. We sort of touched on this in the recording. It was one of the kind of questions that we did the multiple choice question without the scenario. So during that recording, I mentioned that we went through a load of the questions, but they were very like rapid fire, no kind of clinical background, no scenario. It was literally just this is the question. So we can talk a little bit about malaria prophylaxis. So first things first, we can advise patients about prophylaxis against bites. So this is in terms of stopping them from being bitten at all. And then if they are bitten, we can obviously discuss the chemoprophylaxis, but non-pharmacological measures are kind of a really good way of preventing malaria, obviously, because we're preventing the bites. So personal protection against being bitten is very important and is recommended even in malaria-free areas as a preventative measure against other insect vector-borne diseases. So we were thinking about, even when you go to Europe and things, there's no malaria, but you can still get bitten, and obviously that can get infected, and it's best just to try and avoid being bitten at all. So we can use mosquito bed nets, which are impregnated with insecticides such as permethrin, and these improve protection and should be used unless they're sleeping in a well-screened room or the room is fitted with aircon and the mosquitoes can't get in. But obviously that's very difficult to guarantee. So where possible, it's best for people to sleep with a net. When they're out and about, they should wear long sleeves, long trousers and socks, and wear them after sunset. This can protect against bites. Insect repellents give protection against bites, but it's important that the correct application of the product is achieved. So we would recommend that patients use DEET, and this can be available in various preparations, including sprays and modified release formulations. And we would recommend that the insect repellent is at least a 50% insect repellent. So by that I mean once you hit 50% of the product being DEET containing, there's not really much increase. Even if we're going up to like 80% DEET, there's not much benefit. So it's better to just hit 50%. And DEET is safe and effective when applied to the skin of adults and children over 2 months of age. It can also be used during pregnancy and breastfeeding. But it's important that we counsel patients, if they are breastfeeding, that ingestion should be avoided. So any breastfeeding mothers should wash their hands and wipe their breasts before breastfeeding to stop the infant from ingesting the DEET. And we should also, if they're using sun cream, they should put the DEET on after they've put the sun cream on. And DEET reduces the SPF in sunscreen. So we would recommend that they use a high strength sun cream such as 50, because we're going to reduce it a little bit by putting that DEET on afterwards. So there's a few different drugs that are available, and none are available on the NHS. So it's important that we explain to patients that if they're going to a place where they need malaria chemoprophylaxis, they either need to buy an OTC product or get a private prescription. So the OTC products that are available are Maalox Protect, and there's also chloroquine and Progranil. So Maalox Protect is the big one, and that's mainly because chloroquine and Progranil is just not as effective. So we would recommend in most cases that if a patient is buying a chemoprophylaxis, that they buy Maalox Protect rather than chloroquine and Progranil. But there are some places where that's going to be enough and it's going to be effective, depending on the type of bugs that which type of malaria it is, but usually it's Maalox Protect. And the other private prescription options that are available are doxycycline and mefloquine, and they're only available on private prescription. So we would say that we advise that patients speak to their chemist, the pharmacist, or another medical professional before choosing what type of OTC product they need. And we can use Maalox Protect for up to 12 weeks. So we can give a maximum supply of 12 weeks, with the regimen being started 1 to 2 days before they set off on the travels. And this means that the drugs are in the patient's system, ready to fight off as soon as they land or arrive in whatever country it is. They should keep taking the pills at the same time every day to ensure the protection is effective and until the course is finished. And for Maalox Protect, that means finishing the course 7 days after they return to a malaria-free area. And where possible, they should take Maalox Protect with food or a milky drink. If they vomit within an hour of taking the Maalox Protect, then they need to take another dose straight away. But if they're vomiting an hour after, then they're okay. They don't need to take another dose. There's quite a few contraindications to selling Maalox Protect. So if a patient is on a drug like rifampicin, rifabutin, or they're on etoposide, which is a chemotherapy agent, if they're taking metoclopramide, warfarin, tetracyclines, various different HIV and hepatitis medications, we wouldn't recommend its use in patients with a history of depression or seizures, or in patients with TB. And if a patient is pregnant, we would generally advise that don't go to an area where there is malaria, because pregnant women have an increased risk of developing severe malaria and a higher risk of fatality compared to non-pregnant women. So ideally, we shouldn't sell it to them because we wouldn't recommend that they go to a place where malaria is endemic. But we can't sell it to them because if they're pregnant, and we would need them to see a doctor. So hopefully that covers a little bit more about malaria prophylaxis. Has anyone got any questions about that? If you do, we'll come back to it. So just to go through a little bit of an overview of infections. So if you remember from the recording, we've talked about there's 4 different kind of points at which we're looking at infection. So we've got prevention, prophylaxis, treatment, and resistance. So to start off with prevention, how can we prevent infections from taking place? So first things, we can practice effective hand hygiene. And that means we are, this is the most effective way at preventing infections. So we should wash our hands with soap and water, and we can use alcohol hand gel if the hands are visibly clean and there's no C. diff or norovirus expected. And if we are working in hospital and we expect that there might be C. diff or norovirus, so for example, a patient's had a stool sample come back positive, or the ward has had an outbreak of norovirus, we would recommend the use of chlorhexidine. But other than that, you can use alcohol hand gel. And again, this is the most effective way at preventing hospital-acquired infection and preventing spread of infection around hospitals. So we should ensure safe disposal of waste and sharps. So that can help prevent needle stick injuries. So if you or somebody on your ward or a patient reports a needle stick injury, so that might be, it's a needle that has it's either been used in terms of it's been inserted into another patient, and then, as a nurse has taken out a cannula, got it in the finger or something like that, or if you are part of a needle exchange scheme, we want to make sure we're disposing of those needles safely. And if a needle stick injury occurs, we would encourage the wound to bleed, ideally by holding it under running water. So we don't want to stop the bleeding. We want to make sure it bleeds to help clear it as much as we can. We should wash the wound with running water, plenty of soap, and don't suck on the wound. Don't advise patients to do that, and don't scrub the wound while they're washing it, but just wash it gently with soap and keep holding it under running water. You should ring occupational health for some advice. So while whoever it is that's had a needle stick injury is running that underwater, trying to keep it bleeding, we would recommend that you ring occupational health and get some advice from them about what to do next. So you should dry the wound and cover it with a waterproof plaster or dressing. And you might require antibiotic treatment. So for example, you can give if depending on what kind of infection that the patient has, or you want to make sure that you've tested the patient, if you can, for hepatitis B and HIV. So for some patients, they won't consent to that. And you just kind of can't do anything about that. Or if you're in a situation, for example, on a needle exchange scheme, you might not be able to test the patient. So it's important that you speak to occupational health and you either get a vaccination against hepatitis B, or you can have post-exposure prophylaxis for HIV and things. So that's why it's important to ring occupational health to make sure that you get the correct treatment, or nurses or whoever it is that's had the needle stick injury gets the correct treatment. We should make use of PPE. I'm sure obviously you guys have been through your degree during COVID, and you probably all wore masks at some point. And now you're working in healthcare. Obviously, we're not using masks so much anymore. But I'm sure if you're in a hospital or you've been done a placement in hospital during your training year, you'll have noticed that for various different patients, there's like barrier signs on the doors if they're in a side room. So this is another way we can help prevent the spread of infection, is to put patients who have infections in the side rooms. And we can use aprons and gloves and masks. We can use the FFP3 masks to help prevent respiratory infections, or we can use the usual surgical masks all the time to help prevent us giving infections to patients. So thinking about my work on cystic fibrosis, we always wear masks even now because we want to protect the patients from us. So there's reverse barrier as well. So you can barrier a patient against the staff, and you can reverse barrier them, which is where you're protecting the patient from you. And that also happens where patients have a weakened immune system. So for example, on the hematology wards, where they are they've had the immune system wiped out to be able to do a stem cell transplant, something like that, we can reverse barrier. So that's how about protecting patients using PPE. We can also decontaminate equipment effectively. So ensuring that if a patient has been in a bay and had norovirus or C. diff, we're thoroughly cleaning the bay if we can, making sure that the side rooms are thoroughly cleaned after a patient has had an infection in there to ensure it doesn't get given on to the next patient. And obviously we clean whatever equipment has been used. So a lot of equipment is single use, or it's sent off to kind of be steamed and boiled and all those sorts of things to make sure that there's no cross-contamination taking place. So that's prevention. So that's obviously prevention is better than cure. We would like to prevent as much infection as possible. Obviously, it's not always possible, but we can do a lot to protect ourselves and protect patients. So what kind of patients might need prophylactic therapy? So we've got patients who are asplenic, which means they don't have a spleen. So that can be removed for a variety of reasons. It could be because they've had, I've seen it the most commonly on general surgery when they've had major abdominal surgery, for example, post kind of road traffic accident, and they've taken the spleen out. And those patients will then require prophylaxis, usually with phenoxymethyl penicillin long term. And the functions of the spleen are that it removes abnormal red blood cells and it synthesizes immunoglobulins. But you can cope without one as long as you've got some prophylaxis long term. So thinking about working in GP practice, if a patient's had their spleen removed, you want to make sure that their penicillin V or whatever prophylaxis they're on is added to their repeat prescription, so they can continue to access that, because it's not going to be something they just have a course of, it's going to be long term. So we give prophylaxis to patients who are due to undergo surgery, particularly abdominal surgery, because it tends to be a lot messier and there is the risk of bowel perforation. And then you're introducing a whole load of bacteria that would usually be contained in the intestines into kind of the abdominal cavity. So when I worked on general surgery, we would often see patients prescribed cefuroxime and metronidazole, which the surgeons describe as kind of antibiotic bleach, and it gets rid of everything that patients could possibly have if they're having a surgery. So if they're on Kef and Met, we're covering so much that we're getting rid of a lot of bugs. So those due to undergo surgery will often be given prophylactic therapy. Patients who are at risk from infections from bites and wounds might be given prophylaxis. So for example, post dog bite, a patient may be given prophylaxis depending on their risk factors. And we've discussed travellers to high risk areas. So patients who are going to places where malaria is endemic will get some sort of prophylaxis, as we discussed on the previous slide, or we would encourage them to anyway. And then we've discussed a little bit during the needle stick injury. We were saying about post-exposure prophylaxis. So we have in pharmacy in our hospital, we have a kit that is given to A&E for any patient who is likely to have been exposed to HIV, and it's called a PEP kit, and we give it out to patients or staff if they need that post-exposure if they've been exposed to HIV. So that's prevention and prophylaxis. So treatment and resistance. So when treating and managing infections, what kind of things do we need to consider? So this is all about reducing resistance through antimicrobial stewardship. So does the infection need to be treated? And you've probably seen on the news in the last couple of weeks that the government are planning on asking pharmacies to do more in terms of being able to give antibiotics on things like PGDs and prescribe antibiotics where appropriate. I think part of the challenge that's going to come with that is a patient expecting an antibiotic prescription, and the pharmacies and pharmacists, it's your judgment of does this infection need to be treated? And if we're not going to treat it, what safety netting are we going to do to help patients know what to do if it comes back or it doesn't get better? So thinking about, does it need to be treated? We're going to talk a bit later about bacterial conjunctivitis. Does it need to be treated? That's a questionable one, isn't it? But patients want those chloramphenicol eye drops. So it's something to think about, is does it actually need to be treated? And if you're saying no to a patient, or you're saying no if they're asking you for antibiotics, how are you going to approach that? Think about that going forward. So are there any drug allergies? Again, we commonly have patients say that they have a penicillin allergy. Always worth questioning, what is that reaction? Is it nausea? Because that's not a true allergy. Or is it a rash? That is an allergy, obviously. Anaphylaxis, a big no-no. And if they have anaphylaxis to penicillin, what about the cross-sensitivity with cephalosporins? Sometimes we end up desensitizing patients in hospital. And some of my wards have been involved in a kind of trial of patients who have an unknown penicillin allergy or a penicillin allergy from childhood, where it's not suspected that they have anaphylaxis. But what can we do can we give them a trial dose while they're in a controlled environment in hospital where there's resuscitation equipment available? And by that, I mean, we can give them adrenaline to mean that we can help strike out that allergy to increase the range of antibiotics that are available to us. And that might be common in a patient who is down the line with their bronchiectasis. And we've used all the usual antibiotics, and now their Pseudomonas is becoming resistant and we need to give Tazocin. Well, we need to clarify that penicillin allergy. So is the pathogen sensitive to the chosen therapy? I'm sure you've all seen in your area, there'll be different prescribing based compared to national guidelines. A really common example is whether or not your area uses trimethoprim. So in Sheffield, we don't use trimethoprim unless we've got sensitivities that will tell us that trimethoprim is appropriate and for the UTI, and that it's going to be effective. our first line is nitrofurantoin, then it's pivmecillinam, and then it's fosfomycin. We don't use trimethoprim without sensitivities because it's going to increase resistance. So is the pathogen sensitive to chosen therapy? And part of that is also knowing what antibiotics cover for what bugs. And if you're not sure, I used when I was revising, there's a really nice table on Google that has all the antibiotics across the top and then all the different bugs, and it shows what they cover. And that's really helpful in terms of knowing, just for your own kind of personal learning, do you know what bugs cover for what? And part of it you'll have picked up, like, you know that staph grows on the skin. We give Fluclox for cellulitis, therefore Fluclox covers staph. That's kind of my way of thinking about it. Can the prescribed agent penetrate the infection site effectively? So is it appropriate to be given oral antibiotics? Is that going to be enough? And that's a question that I suppose in hospital we ask a bit more, because patients may come in having tried a course of amoxicillin and we need to give them IV Coamox because that's just not cutting it. Or do we need to give a topical preparation, for example, fusidic acid? Is that going to be just as effective as giving somebody oral therapy, putting them at risk of C. diff, putting them at risk of developing overall resistance? So it's better, if we can, to be very specific with our formulation type and to obviously give as specific an antibiotic as possible. And are there any significant drug-drug, drug-disease, drug-food interactions? We always know that statins interact with clarithromycin. Have we counselled the patient to hold a statin while they're on the clarithromycin? Have we asked the doctors to omit it if we're in hospital? What about drug-food interactions? So the obvious ones are kind of warfarin and cranberry juice, tacrolimus and grapefruit. You know, I know that's not antibiotics necessarily, but is it something we need to think about? Does the patient know whether to take it with food or without food? Again, all these questions that we want patients to get the best out of their antibiotics. And do they know that flucloxacillin is 4 times a day and needs to be on an empty stomach? So that's a point where we can make a lot of intervention, is if the patient takes the flucloxacillin with the lunch, the breakfast, the lunch, the tea, and by tea I mean evening meal, and supper, well, then they're not going to get the most out of that antibiotic, and then they might develop resistance. So things like that we need to think about. So I've put this slide on, and I'm going to talk through it. So during the recording, we talked through cephalosporins, tetracyclines, and aminoglycosides. But I thought it might be useful just to touch on a couple of the other ones. So in your packs, you should have the large slides of the quinolones and rifampicin, which are the two I'm going to talk through today. And I know that looks like a lot of information on the screen, but break it down to help you kind of get the most out of these posters so you know what you're looking for. So we'll start on the left-hand side with contraindication. So we'll start with indications, shall we? So the quinolones are your ciprofloxacin, your levofloxacin, and your ofloxacin, as well as moxifloxacin and delafloxacin. But the ones we've put on the slide are the most common ones. So as a ciprofloxacin, probably the most common, the one that I see the most anyway. And it's active against both gram-positive and gram-negative bacteria, particularly active against gram-negative bacteria such as Salmonella, Shigella, Campylobacter, Neisseria, and Pseudomonas. So the reason I see it a lot is because of Pseudomonas in respiratory infections. It also has moderate activity against gram-positive, such as Streptococcus pneumoniae and Enterococcus facilis. But it shouldn't be used for pneumococcal pneumonia. And many anaerobic organisms are not susceptible to ciprofloxacin. And we'll talk a bit more about ciprofloxacin, but obviously it's quite a nasty drug, and it can cause, it's one of the biggest causes of C. diff. So at my trust, it's restricted use. You have to speak to microbiology before you're allowed to prescribe it. That's not the case everywhere. And obviously in outpatients and in community, that's not the case, but in hospital, in Sheffield, you need to speak to micro before you prescribe this. Levofloxacin is active against gram-positive and gram-negative organisms, and it has greater activity against pneumococci than Cipro does. And many staphylococci are resistant to quinolones, so we should avoid the use of quinolones generally, in MRSA infections. So obviously under Cipro, we've said respiratory tract and GI infections, UTIs, gonorrhea. And levo, we've put pneumonia because levofloxacin has that greater activity against pneumococci than Cipro. Ofloxacin is licensed for UTIs, lower respiratory tract infections, gonorrhea, non-gonococcal urethritis, and cervicitis as well. And the other ones are moxifloxacin and delafloxacin. So moxifloxacin is active against gram-positive and gram-negative organisms, and it has greater activity against gram-positive, including pneumococci, than Cipro. So levofloxacin and moxifloxacin are better at gram-positive than Cipro is. And delafloxacin is active against gram-positive and gram-negative, including MRSA. So that's one that we can use for MRSA, but it's usually only used for treating acute bacterial skin and skin structure infections in individuals where the use of standard treatment is considered inappropriate. So we don't use delafloxacin that much, and I don't know about you, I've never personally seen it. I've seen Cipro, levofloxacin, and ofloxacin, and I've seen moxifloxacin a couple of times, but not the delafloxacin before. So fluoroquinolones generally are bactericidal and inhibit bacterial DNA replication. And they're active against gram-positive and gram-negative, as we've said, but levofloxacin and moxifloxacin are active against more gram-positive infections than Cipro is. So the keynotes, we've got avoiding pregnancy, and that's one of the MRSA alerts. So there is a lot of MRSA alerts for the quinolones, and we'd recommend that you look those up and you know what they are. And in pregnancy, it can cause arthropathy, and it can, the other MRSA alerts, so we're sort of coming down to this contraindications and cautions now. So we've got quinolones may induce convulsions, so we shouldn't use them in epileptic patients unless there's no other option. And I have seen it done before, but sometimes it's something I always flag up to the medical team is, do you know that this patient's got epilepsy and these can reduce seizure threshold, so we wouldn't recommend the use of quinolones. There is an MHRA alert about tendon damage, including rupture, which has been reported rarely in patients receiving quinolones. And we shouldn't use quinolones in patients who have a history of having tendon damage, and we shouldn't use them in, we should try not to use them in patients who are over 60 because they're more prone to tendon damage. But to be honest, we still do that. We just would monitor it more closely. And if we suspect that they've got tendinitis, we would discontinue the quinolone immediately. And this is with both intravenous and oral use. Fluoroquinolones can cause arthropathy in children and adolescents, and therefore they're not recommended in this age group. Another MHRA alert is about systemic and inhaled fluoroquinolones, as there's a small increased risk of aortic aneurysm and dissection. So it's a risk-benefit decision in patients who are at risk of aortic aneurysm and dissection. And we should inform patients who are particularly elderly and those at risk about the rare events of aortic aneurysm and dissection, and advise them to seek immediate medical attention if they experience sudden onset severe abdominal, chest or back pain which develops. We've got on here patient and carer advice. So norfloxacin should be taken on an empty stomach. And as I've mentioned, the aortic aneurysm MHRA alert, we need to inform patients about that. The adverse effects include heart valve QT interval prolongation and the tendon rupture that we've discussed already. So we should contact the GP immediately if there's a serious adverse event, such as tendinitis or tendon rupture, and if they experience any signs like muscle pain, muscle weakness, should advise them to speak to their GP. There is one more MHRA alert which came out in December 2020, which is there is a small risk of heart valve regurgitation, and we should consider therapeutic options first, other therapeutic options first in patients who are at risk. So there's quite a lot of MHRA alerts about the quinolones, and we would recommend that you have a look at those. As we've mentioned about quinolones can induce convulsions, it's particularly prevalent with NSAIDs. So we would ask patients not to take NSAIDs with quinolones. And quinolones can also increase the anticoagulant effect of warfarin. Hopefully that's a little bit more about the quinolones, we're next going to talk about rifampicin. So rifampicin is there's a lot of interactions with rifampicin, as I'm sure you're aware. So we'll start again with the indications. So we use it for brucellosis, endocarditis, Legionnaire's, meningococcal meningitis, multibacillary and pulsibacillary leprosy, and tuberculosis. This rifampicin is not a drug that we see that often. It's horrible to take. Patients really struggle to take it, and there's a long list of side effects. So, and because it's an enzyme inducer, it interacts with everything. So it's not ideal for patients to be on rifampicin if we can avoid it. So it's a semi-synthetic antibiotic, and it exerts its activity by inhibiting DNA-dependent RNA polymerase activity, and it suppresses synthesis. And it's really broad spectrum. And the reason we use it in things like TB and leprosy is because it's active against most atypical strains of mycobacteria. So it's for those conditions where mycobacterium are the cause is when we're using it, and we're not using it for much else. So in terms of counselling points, we should inform patients and their carers that it can discolour their contact lenses and urine and tears. So it might turn them red and orange. And personally, I like to try and warn patients about this before we start them on it, because I think it's very disconcerting for a patient to suddenly have red urine. So important to try and tell them first before they start taking it. We should give it on an empty stomach, ideally half an hour before food, usually in the morning. Otherwise, it can be taken 2 hours after eating. So we'd usually say, wake up, take it, and then half an hour later, you can have your breakfast. There are serious side effects, including liver toxicity. So patients should be advised to report signs of liver toxicity, which we've got on the slide. So jaundice, persistent nausea, vomiting, malaise, that could be a sign of the liver toxicity. And as we've mentioned, it's an enzyme inducer. So we should check it with other medication, including oral contraceptives, to make sure it's still appropriate. The adverse effects are quite large, as you can see. So we've got agranulocytosis, nausea, vomiting, menstrual disorders, thrombocytopenia, as I've mentioned, tear discoloration, urine discoloration, and soft contact lenses discoloration. Other side effects include psychosis, and if we use it intravenously, which to be honest, I don't see that often, patients may get bone pain, GI disorders, hyperbilirubinemia, and psychotic disorders as well. So it's quite a nasty drug. And as I mentioned, there's loads of interactions, and it's because it's a potent hepatic enzyme inducer, and we can say it's the mother of all inducers. So it interacts with DOACs and warfarin, and at my trust, we wouldn't use rifampicin with a DOAC, but we would with warfarin, because obviously with warfarin, you can monitor the INR, make sure it's effective, which is a lot harder to do with DOACs. But again, if a patient's been started on rifampicin, they're usually on a load of other TB medications as well, and that doesn't tend to suit them. So warfarin's already tricky enough. So it's not ideal, to be honest. If we can avoid rifampicin, we do. Interacts with PDE5 inhibitors, cyclosporin, macrolides, clozapine, contraception, which is obviously a big one in females of childbearing age, mycophenolate and verapamil. So a lot of interactions. It's an enzyme inducer, so whenever I see rifampicin, I run all the drugs through the interaction checker just to be safe. It's contraindicated in acute porphyrias and in patients with jaundice. And if patients are alcohol dependent, they should have frequent checks of their hepatic function and full blood count, and that's because of that risk of hepatic toxicity. So we should check the renal function before treatment, as well as doing a full blood count if patients are on prolonged therapy, and again, hepatic function, keep an eye on. And if they're on it for TB, they're going to be on it for a long time, so we need to be keeping an eye on those things. So we're going back to some of the tables that we covered in the recordings. Hopefully, has anyone got any questions as we go? So I've just put this Clostridium difficile colitis table in the slides again, because there's a slight change to the first and second line treatments from what we covered in the slides. So Clostridium difficile colitis is caused by C. diff, which is a gram-positive spore-forming anaerobic bacillus. and it can cause severe pain, cramping, diarrhea, nausea, vomiting, blood in the stool and feces. So as we said before, this can be caused by drugs. So it can be caused by ciprofloxacin, quinolones generally, PPIs, by broad spectrum antibiotics, because what tends to happen, clindamycin, for example, what tends to happen is patients might be a carrier, and then we give them a broad spectrum antibiotic. We wipe out the natural kind of bacteria that are living in the gut, and then Clostridium difficile can replicate and cause C. diff colitis. So it's not pleasant. It should resolve in 1 to 2 weeks, and the person will remain infectious while they have symptoms. So they have to stay away from work or school until they've been free from diarrhea for 48 hours. We should avoid the use of anti-motility drugs. So we should encourage patients to remain hydrated, stop the causative antibiotics, and if we need to, we can give fluids, and we need to ensure that we treat it effectively. So on the slides originally, it said that metronidazole was the first line, but actually we use vancomycin first line. So this was quite a recent update to the NICE guidelines. So we use vancomycin as the first line therapy. And second line, we use fidaxomicin. In hospital, if it's severe infection, we can use vancomycin with metronidazole, but we give the metronidazole IV rather than orally. But in community, first line vancomycin, second line fidaxomicin, and we can add in metronidazole. But this should always be discussed with micro, even in community, because you need a positive stool sample, and we want micro need to be aware, and they can advise on which antibiotic to give. And there's a nice table on the NICE guidelines that talks you through when to use which antibiotic. We use 10 days of antibiotics, and the greatest risk with C. diff is with clindamycin and cephalosporins, especially the 4th generations, fluoroquinolones, broad spectrum and or combination penicillins, as we've said. So just make a note of that on the slides that you've got, that the treatment is slightly different to what we mentioned during those slides. One of the other tables that you had that we didn't talk through, and I thought I would now, is oral candidiasis. So the most common causative organism is Candida, and I'm sure plenty of you have seen oral candidiasis, oral thrush as it's also known. And the symptoms our patients present with a curd-like white or yellowish plaques that can occur anywhere in the mouth, especially the cheeks, gums, palate and tongue. And patients can have pain, which can make eating and drinking difficult, as well as a loss of or altered sense of taste. First line, we would usually give meconazole oral gel or nystatin suspension. And obviously we can sell meconazole oral gel. So in pharmacy, that's really helpful. And we would, if a patient presented with thrush, we want to be sure it's thrush, so we can obviously have a look. Make sure that there's no red flag criteria or any referral criteria. So a referral criteria would be when the OTC product is not suitable. So for example, they've already tried meconazole oral gel, it's not got better, then that's a referral. We would consider referring for patients with diabetes because it could be linked to hyperglycemia. And I think this would be on a case-by-case basis in terms of how often they're getting thrush. And obviously patients are saying at the moment it's really difficult to get in with a doctor. So you might say to them, look, I'll give you the treatment this time, but you need to see a doctor to be sure that there's nothing else going on. But I can give you this now and this will fix the problem, provided you book in with a GP. In immunocompromised patients, unexplained oral thrush can be a HIV indicator. So we want to refer them if we think that that might be the underlying cause, as well as if it looks at all like it could be malignant. So leukoplakia, which can be a white patch or plaque that cannot be rubbed off, would be a referral criteria, as well as if we think that they've got suspected erosive lichen planus, which is more tender erythema and painful ulcers, which are surrounded by white radiating striae, as that could be, needs a biopsy, and it could, if you suspect oral cancer. We would refer pregnant patients to the doctor, and if they're breastfeeding and it's the baby that's suffering with oral thrush, we would recommend that the mother speaks to the doctor, because they might require nipple covers if they're breastfeeding, because we don't want that transfer of, again, infection prevention. Second line, we can give oral or fluconazole capsules. So obviously topical treatment, fluconazole oral gel, nystatin suspension. If that's not working, we can switch to fluconazole. We would hope that they just last for 7 days, but they should continue for a week post-symptom resolution to ensure it doesn't come back. And topical azoles are more effective than topical nystatin. So meconazole is the best if we can. But remember the big interaction between meconazole and warfarin, as I'm sure you're all aware. And we would give non-pharmacological advice such as good dental hygiene, smoking cessation and denture care, as well as rinsing the mouth out after using a steroid inhaler. So the last table we're going to cover before we move to our multiple choice question is bacterial conjunctivitis. So the difference between allergic and bacterial conjunctivitis is that in allergic conjunctivitis, both eyes are affected, whereas in bacterial, it tends to just be one eye, which might progress to the other, but it tends to start in one. And allergic tends to have bloodshot, gritty, itchy eyes with a very watery discharge. And it might have sneezing associated, runny nose. So it's more of like a hay fever symptoms as well. Whereas bacterial is characterized by the red eye with a mucopurulent discharge. And for allergic conjunctivitis, we can give sodium chromoglycate drops, as well as treating hay fever with oral antihistamines and nasal steroids if required. But back to bacterial, usually caused by Staph aureus, Streptococci pneumoniae, and Haemophilus species, but it can also be caused by chlamydia. So, as I said, usually unilateral, and we would manage it. First line is self-care measures, and as I mentioned on the first couple of slides, patients don't really like that. They want the chloramphenicol, but we would prefer not to. And we can manage it using non-pharmacological measures, such as bathing and cleaning the eyelid with a cotton wool which has been dipped in sterile or boiled and cooled water to remove the crust, and keep wiping it away, obviously away from the eye that's not affected. In terms of referral criteria, it's when a patient has pain in their eye, because that could be a sign of something else, such as angle closure glaucoma, which is really urgent, and we would want them to be seen for that. If their vision is at all affected, we would refer, and if they've got any irregularly shaped pupils or issues with dilatation, or they're experiencing photophobia or severe swelling, again, that's a referral criteria. Bacterial conjunctivitis is usually self-limiting and resolves within 5 to 10 days, and they don't need to stay off school or work with it. So we can sell the chloramphenicol, so it comes as a drops in an ointment, and you would follow the instructions on those for when to sell and when not to. And remember, it's not safe to use in pregnancy. And we can give fusidic acid with a prescription. So, bonus multiple choice question. So this is all about TB counselling. So Mrs. S is 65 years old. She's presented in hospital with night sweats, cough and hemoptysis. The medical team have diagnosed TB through a sputum sample, and there is no nervous system involvement, so she started on standard therapy, which is isoniazid with pyridoxine, rifampicin, pyrazinamide and ethambutol for the first 2 months, and then they'll step her down onto slightly different therapy. So you're covering the ward and you need to go in and counsel the patient. So which of these is the least appropriate counselling point? Just have a think about it. I'm going to set up a poll and we'll have you answer on that. If I can get this to come down. Let me go back, sorry. Can we set up a poll? Maybe we can't set up a poll. Sorry about that. So just put your answer in the chat when you know the answer. You can send it to just me if you don't want to send it to everyone. So which of these is the least appropriate counselling point? So remember, she's been started on isoniazid, pyridoxine, rifampicin, pyrazinamide, ethambutol, so 5 drugs. Does rifampicin need to be taken on an empty stomach? Ethambutol can cause visual changes, and patients should report any changes in their vision as soon as possible. Isoniazid can cause peripheral neuropathy, and patients should report any tingling in their extremities. Isoniazid should be taken with food, or pyrazinamide should be taken with food. So which of these is the least appropriate counselling point? If you want to pop your answer in the chat, and I'm happy to give you a couple of minutes if you want to go away and look up some of these drugs in the BNF to see. So 4 of these are the correct counselling points and 1 is incorrect. I'll just give you another minute. Sorry, I thought I'd be able to set up a poll, but I'm not sure how to do it. Oh gosh, keep clicking. So we've got a few people in the chat saying D, which is the correct answer. Well done. So I mentioned on the rifampicin slide that rifampicin needs to be taken on an empty stomach, and so does isoniazid. So rifampicin and isoniazid empty stomach, but pyrazinamide with food. Ethambutol can cause visual changes. So we do what's called a Snellen test on patients who are starting on these drugs. And it's basically pretty similar to what you do at the opticians, where there's like a board with letters and you have to read. So it's a very simple test, and it should be performed as soon as possible when using ethambutol. And patients should be advised to report any visual changes, such as tunnel vision or loss of colour perception, as well as any blurred vision. And then the score is recorded as the number of the smallest whole line that they can read. So we would usually ask patients to do it with the glasses on, because obviously we want them to be able to see, and we would just write done with glasses. They do 1 for each eye, and the eyes might need to be reassessed depending on what comes back. So isoniazid can cause peripheral neuropathy, and patients should be reporting any tingling in their extremities. So as we've mentioned, we're giving isoniazid with pyridoxine, and that's because pyridoxine is given as a prophylaxis to help prevent the side effect of peripheral neuropathy, which is caused by isoniazid. So if the symptoms occur, we can increase the pyridoxine or stop the isoniazid, depending on the clinical picture. I really didn't click it then. Let me go back. Woo! Hang on. There we go. And other side effects of isoniazid are that it needs to be taken on an empty stomach, but it can cause GI upset. And we would usually take it for the duration. So if it's for 6 months, they'll continue the isoniazid. With rifampicin, we've discussed the counselling points already. And for both isoniazid and rifampicin, there's the risk of liver toxicity. So we want to encourage patients to report any signs and symptoms of liver toxicity, such as if they have any kind of jaundice, any nausea, vomiting, any kind of liver pain, anything like that. We want them to tell us, but it's going to be difficult to know whether it's caused by the rifampicin or with the isoniazid. And pyrazinamide most commonly causes nausea and vomiting, which is why we recommend they take it with food, because it doesn't really matter. But if they take it with food, and we can use antiemetics with it as well if patients are experiencing nausea and vomiting. So that is the end of our layout of end of the drop-in session. Has anyone got any questions about infections or about any about your exam prep, anything like that? I'm happy to answer for the next sort of 5 minutes, and then we'll wrap up. If anyone has any questions, anything they want help with or anything like that. If not, no worries, but seeing as we're here. And remember, obviously, you can ask any questions in the WhatsApp group, get in touch through that. And you've obviously got another session on law and ethics and exam prep as well. So someone's asked, what are the best resources for revision for clinical and maths? Our clinical is the BNF basically, isn't it? So what I did was I used obviously these notes from these sessions are really good. They cover a lot, but it's the point when you're thinking, oh, you want to make it stick, don't you? So I found that looking at lots of different resources helped. So I used the BNF treatment summaries from the website rather than from the book. And I just worked through them A to Z. And that also helped me contextualize the learning. So I've said it in the recorded sessions, I find it easier rather than sitting down and learning about calcium channel blockers, learning about them in the context of hypertension, and learning about them in the context of when to use them in like heart failure and, you know, all those kinds of things, when not to use them. I found it easier to fit it in to learning about how to treat a condition rather than learning about contraindications, the interactions. Like that just doesn't work for me. So that's how I did it, was I approached it by looking at the treatment summaries. So I'd learn the hypertension pathway, and in doing that cover all these different drugs, or I'd learn the heart failure pathway and again cover the same drugs but in a different context, which helped make it stick. Does that make sense? In terms of maths, you just need to practice. It's dull. I can't tell you anything else, unfortunately. You just have to sit down and get hold of obviously there's only a certain number of types of questions that they can ask you. That's all available in the stuff that's on the GPHC website. They tell you the different types of questions, don't they? You know, in terms of whether it's dilutions or kind of tablet counting, whatever it is. And I really struggled with the ones to do with like pessaries and suppositories and base ratios and all that kind of thing. And I would just kind of practice those ones that I really struggled with. Obviously we've got a mock exam. That's the easiest way, is just to sit down and practice and get good at knowing know what topic you struggle with in terms of the maths, and practice those maths questions over and over. I'll put a link up to the WhatsApp group now, actually. Somebody just asked, how can I join it? So that's just to say that you've covered all this stuff and we've ticked infections. So next week, the law and ethics and exam prep recording will be available, and then there'll be a drop-in session on that as well. I'm sure the WhatsApp thing's at the end. There we go. That's just scan the QR code and you should be able to join. Somebody else has asked, do we have to know the CV infections and CNS infections, including treatments which in the BNF? It's really hard to answer the question of what you need to know in terms of the BNF, because I don't know what's going to come up on the exam. And the question I would ask yourself is, does a day one pharmacist need to know this? And that's what they're assessing with the exam, is as a very general, on day one, you should be able to work in any sector. You should be able to walk in, and would a day one pharmacist need to know this? So for example, would I expect a day one pharmacist to know that flucloxacillin is taken on an empty stomach? Yes. Would I expect a day one pharmacist to be able to advise about dosing based on a level of vancomycin without any help? No. So, but would I expect them to be able to do it with a resource? Yes. So that's how I would approach these questions, is if you're given the information, would you be expected to be able to know how to interpret it? Probably. But what would you expect to know off the top of your head? That's a question for yourself of, does a day one pharmacist need to know this? So I can't tell you, do you need to know this topic? Because it's, does a day one pharmacist need to know it? And that's a decision that you kind of have to come up with. Somebody's asked, what source would you recommend for skin conditions, specifically for the questions we get given pictures in the exams? I think, let me just, there's a website, I'm just trying to remember what it's called. So there's a website called DermNet NZ. And they have images of lots of different skin conditions, A to Z. I'm just looking at them now. Just hold my iPad up so you can see. So that's quite a good resource for photos. It tells you can just look through there. So that was one I used, was that DermNet NZ. What date is the May session? Let me look. Top of my head, I don't know, and I might have to get them to let you know about that. But let me check what date it is, if I can find it. Contact us courses. Don't know about if there's feedback sessions for the mocks. Oh yeah, there is a live mock exam feedback session. Yes, when you go on the website, it says there is, but I don't know when it is. So what I'll ask Imran or Atif to do is let you know about the dates for those. And because I don't know off the top of my head, and I don't want to give you the wrong date. So I will ask them, everyone that's, it'll definitely be on your like Pharmacy Foundation's Moodle page. It should tell you on there when it is. And someone's asked when is the next drop-in session. Again, I'm not sure. If you keep an eye on social media, oh, somebody says, think the 4th of June. I don't want to, hopefully that's right. If not, check on social media. And what I'll ask Imran or Atif to do is just send that again on your like Moodle page where you access all the recordings. It should say on there exactly when they are. But I don't have access to that because I don't upload the content. So I would just go to that page and see if it says on there. But Erin says think 4th of June, so I hope that's right. But if you're wanting to attend the free and drop-in sessions, keep an eye on social media and that'll tell you when they are. Is that all right for everyone if we wrap up? Thank you so much for attending. And I wish you the best of luck with your exam. Hope it goes really well, and just look after yourselves in the next month. And hope it goes really well. Thank you all so much for attending and engaging. Hope it's really helpful. Bye.